All right, well, thanks for coming out on a kind of grayish Thursday evening. These are lectures that the new Lehigh Valley Orthopedic Institute is trying to put out just to, introduce you to our different divisions and give everybody a chance to learn a little bit, ask some questions, meet some of us face to face. So I'll go through my whole history, but briefly until we go through the video. My name is Jason Rudolph. I'm an orthopedic surgeon. I've been practicing in the Lehigh Valley for 20 plus years now. We'll go through some of that. Recently, Lehigh Valley Health Network started what we're calling institutes. And although I know there are other ones, the only one that I care about is our Orthopedic Institute. So our Orthopedic Institute essentially is combining orthopedic surgery, rheumatology, pain management. I'm going to forget some other groups, but essentially everything musculoskeletal, which means from the neck down, not including the chest and the belly. So we take care of all those problems from soup to nuts. I've recently been named the chief of the division of foot and ankle surgery. So foot and ankle is pretty much everything, from the middle of your leg bone down. I have some familiar faces in here, and as a lot of you folks know, I do other things as well. I do a lot of the trauma, a lot of the fracture work, so I'm also part of the fracture and trauma division, but being head of foot and ankle is what they asked me to sort of present tonight. And so we're going to kind of go through some basic foot and ankle problems. I titled this Everything You Wanted to Know About Foot and Ankle Surgery, but we're afraid to ask. So once I go through it, maybe 20-minute presentation, maybe a little longer. At the end, we'll have some open time for question and answers, okay? So we'll get rolling. So again, who am I? I'm an orthopedic surgeon, like I mentioned. I specialize in foot and ankle and trauma. Trauma meaning broken stuff. I've been in the region for well over 20 years now. I'm a board certified orthopedic surgeon. I live locally. I treat my patients like my friends and neighbors. Some personal stuff. I did play Division I football, so I suffered most of the orthopedic injuries. And if you see me limping around, it's thanks to old football injuries. So what's an orthopedic surgeon? You have to go to college. Of course, I went to 4 years. I'm a graduate of Princeton University. You have to go to med school, which is 4 years of medical training, just like your general surgeons and your orthopedic surgeons and your pediatricians. So I went to Chicago. After medical school, you do a residency. So orthopedics is a 5-year residency where you learn everything from the toes to the spine. So we do a little bit of everything during our 5-year residency. I trained at Monmouth Medical Center, which is in New Jersey, if nobody knows that. Then after I graduated 5 years, I did a foot and ankle fellowship and a trauma fellowship. That was at Vanderbilt University in Nashville. So what I like to say is I graduated from 26th grade before ever having my first real paying job. So, jumping right into it. Myth number 1, do high-heeled shoes cause bunions? No. Bunions are inherited. So take a look, if you have a bunion, take a look through your family. Your mom, your dad, your grandparents, somebody has bunions. People that have never worn shoes can have bunions. That doesn't mean that if you wear narrow pointed shoes, it might not make your bunion more symptomatic. So the first step in anybody who has a bunion is wear a wider shoe. That's simple, that's easy, there's no surgery involved. In the old days, when you bound your foot or strapped it, like in the ancient Chinese culture, sure, you could develop bunions, but that doesn't happen today. So shoes can't cause bunions, despite the pretty pointed shoes. That's an x-ray of somebody in a shoe, and you can see that even if you don't have a bunion, you wear those tight, pointy shoes, it's going to rub, it's going to hurt. Myth number 2, are ankle sprains worse than broken bones? So first of all, what is a sprain? A sprain is an inversion injury, a fancy way of saying you roll your ankle in. When you roll your ankle in, you can stretch out ligaments. Ligaments are ropes. They're bone. They connect bones together. So we have ligaments everywhere. Anywhere where you have a one bone connecting to another bone, there's a ligament. So those are the ropes that hold the bones together. When you roll your ankle, you can stretch out a ligament. And stretching out a ligament is the same thing as a sprain. So you can say sprain, stretched ligament, torn ligament, all that is essentially a sprain. Ligaments don't usually rip in half. They're more like plastic, like a plastic bag can kind of stretch. Normally that's what happens. The ligament everybody knows in the knee is your ACL, that's a ligament. That is one that does tend to rip in half. The rest of them kind of stretch. So this is a very busy slide. And if you ever come to see one of us and somebody tells you have a sprain, we can grade them 1 through 3. And it's pretty much self-explanatory. Ones are the simple ones. You step on a rock or a pebble or a black walnut and you sprain it. The next day you're feeling back to normal. That's kind of a 1. A 3 is not the opposite end. These are the severe ones where you may tear 1, 2, 3, even all 4 ligaments in your ankle. Those you can't walk on the next day. It takes a week or 2 till you finally put weight on it. Those are the ones we like to see in the office because they can become the ones that become more problematic as time goes on. Those are the ones that we usually will brace you for a little while, get you into therapy. But the good news is, from 1 to 3, nobody does worse than the other. They all do generally pretty well. This is looking at your ankle from the side. The fibula is the little bone, the tibia is the big bone. And you see this thing, it says anterior talofibular ligament. Fancy name for the ligament that goes from the fibula to the talus. So that's your big ligament. Then the other 2 run here and one that runs in the back. So those 3 ligaments about your ankle are the ones that you sprain if you ever roll your ankle. So how do you treat an ankle sprain? RICE is the fancy term that just about everybody in the room knows. Rest it, ice it, compress it, and elevate it. And we gave you free ice bags. So everybody has an ice bag here. So everybody has an idea on how to ice their ankles from now on. The more severe, the grade 2s and the 3s are the ones that show up in my office. Those we usually put you in a sports brace as soon as we can. We don't like putting in casts. We like ankles to start moving. The sooner in the longer in your cast, the higher the chance of it getting stiff. So we like to brace you and get you in to see our therapists. And some people go for 1 visit, some people go for 10 visits. It all depends on what it takes to get you back to your full activities. Like I said here, 85% of even the most severe sprains do just fine. It's very rare that anybody ends up with surgery after a sprain, but not unheard of. Not something that happens within the first 3 months or usually even 6 months. But if you have a really bad sprain, you tear all those ligaments, and like I said, that plastic bag stays stretched out, those are the ones that potentially end up with surgery. Now what about a fracture? Ankle fractures are very variable. A fracture means, here's the one thing, is a fracture and a break are the same thing, just to clear that one up real quick. So fractures means something breaks on the bone. Usually bones can heal without any real incidents. Talking about which bones can be fractured, is it a stable fracture, does it involve a joint? Each of those things, if you fracture more than 1 bone, that's worse. Stable means it's a fracture that you can walk on right away. And involving a joint is always bad. Anytime you break a bone anywhere near a joint, whether it's your ankle, whether it's your knee, whether it's your finger, then that's a bad fracture because we don't like fractures in joints. I put this picture up here because if you look really closely, there's a teeny, teeny little fleck of bone right there. Well, that little fleck, sure, that's a fracture, but that's a fracture I wouldn't mind having. Now that's a fracture you don't want to have. That's a big fracture of the ankle where we had to use a long plate and screws, and it does involve the joint. So that's one of those fractures that, yeah, that's a fracture I might not want to have, and I'd rather have a sprain. So in conclusion, are ankle sprains worse than a broken bone? The majority of the time sprains can be treated conservatively. They almost never require surgery. Most ankle fractures heal fine, but some can require surgery. So in general, I guess I'd pick a sprain over a fracture. All right, this is a super common problem. The most common problem that we see in the office for sure in the foot and ankle division. And the question is, I have a heel pain, it must be a heel spur. I have a spur, that's what I've got, right? Well, let's go into this a little bit. So heel pain has lots of causes. Far and away, the most common cause is plantar fasciitis. And we'll get into that right now. It's the most common thing. The classic finding is you're worse in the morning. You wake up in the morning, can't put your heel down, take a few steps, and it starts to loosen up. Achilles tendonitis, that's pain in the back of the heel. That one usually happens more after activity, not really waking up in the morning. Bursitis, that can be just sort of a pain right on the bottom of your heel when you walk, or if you've landed funny, you get a little swelling there. Stress fractures we'll get into. Fractures are again, another thing that can happen in the heel bone. So the first one, Achilles tendonitis. The Achilles tendon, most people know that tendon. That's the long, flat tendon that's in the back of your calf, right? It goes from your calf muscle right to your heel bone. So that's your Achilles tendon. The blood supply comes from the muscle above and from the bone below. So there's a watershed area in the middle there that doesn't have a great blood supply. So if you have a little tear in that tendon, or in the middle of that tendon, sometimes it can become a long-term problem that doesn't get better. So the middle section is the section where you not only do you get tendonitis, but that's the spot you can also get some small tears. So symptoms of Achilles tendonitis, pain on the back of that tendon. Or you can have pain right where the tendon inserts onto the bone. It's usually worse after exercise, can be bad in the morning, but usually gets better as you stretch it out or as the day goes on. Risk factors, again, this is, I mentioned patella tendonitis, that's related to another talk I had done. But essentially it's an overuse injury. And overuse injuries are those kind of injuries that don't occur from one time, but say you start playing pickleball and all of a sudden that pain in the back of your Achilles starts to hurt. Very common problem. It's usually caused by microscopic tears of the tendon and can progress all the way to long-term tendon problems. So that's a picture from the back. That's your calf muscle above. It becomes this sort of white fascia stuff, and then it becomes this most important Achilles tendon down here at the back of your ankle. So how do we treat Achilles tendonitis? Well, 99% it's non-operative. Stretching, bracing, casting. One thing I mentioned here, although I use a lot of cortisone injections, never let anybody put an injection in your Achilles tendon. If you get one injection in your Achilles tendon, it can actually rupture it. So we do not want tendons in your Achilles tendon specifically getting an injection. There's some other things out there. People talk about PRP and sound waves, ultrasound shock waves. I don't even think we should talk about those. They're sort of experimental at best. When do we operate on Achilles tendons? Only after you've failed lots and lots of conservative care. And by that, I'm talking months of therapy, stretching, shoe wear modifications. That being said, some of them do get surgery. The insertional ones, the ones that insert right in the back of your heel where you can develop a big bone spur, sometimes we have to operate there, shave the bone spur, clean the tendon up, and then reattach the tendon. Tendinosis, that's thickening of the Achilles tendon. How do we treat that? Well, you can resect the middle part of the Achilles tendon, clean that up, transfer a tendon. This is the big one. This is the most common one. I'm sure almost everybody in the room either has this, knows somebody who has it, or thinks they might get it. So plantar fasciitis is the most common cause of heel pain. It's caused by microscopic tears of that plantar fascia. So the plantar fascia is this band of tissue that runs from the bottom of your heel all the way out to your toes. It helps in giving you an arch. Not the only thing, but it's one of the things that helps to give you an arch. Symptoms are classic. First, waking up in the morning, I can't put my heel on the ground. It hurts like crazy. Then as I take a few steps, it stretches out, it starts to feel better. And it's been, again, pain after activities. I mentioned that it's caused by small tears in that band of tissue, super common, worse in the morning. Why do you get it? It's hard to say. Sometimes it's overuse, sometimes you gain weight, sometimes you're trying to lose weight, sometimes you take up a new activity. Most of the time we don't know. Treatment. Well, here's a picture first. So that's the picture of that plantar fascia. So that's the back of your heel. You see that red spot? That's exactly where the plantar fasciitis occurs. Like I said, this band goes all the way out to the front of your toes. It's causes, overuse, weight gain, new activity, unknown. Treatment. It's almost always non-surgical. And by almost always, I mean like 98% of times we don't operate on these things. No worries. So what's the treatment? Stretching, 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 more stretching. Now you can stretch by using an orthotic, which is an insert in your shoe. You can wear night splints. You can do a stretching program that will teach you most commonly. Sometimes cortisone shots. It's a spot that's a little painful, so it's not the first thing we do. Some people that just have recalcitrant pain that's just not getting better, we can do a quick cortisone shot to make it feel better. Surgery is rarely done here. It's only if you've had 6 to 12 months of stretching. And if we do surgery, it's the ultimate stretch. Make a little incision, kind of snip that fascia. Next problem that can occur in the heel, like I mentioned, was stress fractures. Now, stress fractures can occur anywhere in the body, most commonly somewhere from the hips down. We see it a lot in the foot and the ankle. Think of a stress fracture like a paper clip. So you have your bone, you bend it, you keep bending it, you keep bending it, you can get those little teeny cracks in it, and that's where a stress fracture is. So those little cracks don't always show up on x-rays. That's why if somebody comes in and we think they might have a stress fracture, x-rays are normal, then we'll usually go to an MRI scan. They can occur anywhere. I've seen them in hips, femurs, knees, ankles, but lots and lots of people get stress fractures in their feet. One thing that we're kind of promoting a lot these days is bone health. And one of the reasons you can get a stress fracture is not only from taking up a new activity, but you can have lower vitamin D. So we check your vitamin D. You can have lower calcium intake. And then there's plenty of other hormonal causes for lower bone health. So we've started a new bone health clinic. We can talk about that at some point later. But the one that I usually focus in on is vitamin D. Everybody should be taking vitamin D every day. 2,000 IUs, one tiny little pill. If you get a stress fracture, we'll check you. And if you're too low, we'll give you some vitamin D boosters. So again, treatment of stress fractures, eliminate the stress. We can put you in a cast, we can put you in a walking boot, modify your activities, sometimes bone stimulators, injections, and extremely rare that we operate on stress fractures, but can happen. This one snuck in here, but we'll talk about hallux rigidus too. Sure. I don't know how that snuck in here, but I'll be happy. This is another common problem. So hallux rigidus is basically arthritis of your big toe joint. It's a fancy way of saying arthritis of your big toe joint. Big toe joint is a super common area to take a lot of stress. Everybody knows about hips and knee arthritis, but your big toe joint probably gets more arthritis than anywhere else. Very common in athletes, runners, anybody that's up on their feet a lot. And this is a picture, so when I'm saying the big toe joint, that's your metatarsal, that's your toe, and the area of all the problem is right there in the middle of your big toe joint. Sometimes it's related to a single injury, like a football injury. That's what turf toe is. Somebody is pushing off on their toes. Some other player can land on the back of their heel and really dorsiflex that toe. It can be from repetitive activity, or again, it can be unknown. But it's pain right at what we call the first metatarsal phalangeal joint, or essentially your big toe joint. Symptoms, pain, swelling, you think you may have a deformity, and most commonly it's limited motion. The way we diagnose that is pushing on your foot, number one, and then doing some x-rays. Treatment, again, as you can tell, the line here, almost everything we try to treat non-operatively first. Changing your shoes, wearing inserts in your shoes to take some pressure off of your big toe. Sometimes a cortisone injection to make it feel better. NSAIDs, everybody doesn't know what that is. That's basically Advil or Aleve or one of the fancy prescription ones. Operative treatment, yeah, if that fails. If the injections and the therapy and the inserts don't work, we can treat it. If you have mild arthritis, it's one of the spots we can just do kind of a cleanup surgery, shave the bone spurs, get your toe moving a little bit. Most of the time it's a little more advanced than that. We don't like doing joint replacements in the big toe joint. It takes a lot of pressure, it fails quickly. Imagine your entire body weight going through your tiny little toe joint. So that one would fail, so we don't do that like in hips and knee replacements. In the big toe joint, it's more of a fusion, where you take those two bones that hurt so much and we fuse them together. It becomes one big joint, one big bone. Achilles ruptures, we'll go into that too since it's on here. Very common in the 20 to 40-year-old age group. Everybody in here fits that classification, so we'll talk about that too. Essentially, Achilles rupture is where you have an eccentric force on a tight tendon. So you're pushing off on a tendon. Again, pickleball, super common, becoming more and more common. We're seeing this all the time now. So essentially your Achilles tendon is already tight and you push a strong force on that already tight Achilles and it can rupture. And here's a picture of a former Phillies first baseman who tore his Achilles running to first base. Symptoms, snapping, tearing sensation in your heel. People think that somebody kicked them or shot them from behind. You have weakness, you have inability to push off. Most of the time you can diagnose this in the office almost from across the room. Treating it, in the US, we still treat these things operatively most of the time. If you're not healthy enough to have surgery, if you're adamantly against surgery, it can be treated with a cast, but still most of the time in our practices we repair these surgically. You repair the tendon side to side. You're in a boot, but we like to start therapy usually within the first 3 weeks. And most of the time, you're back to sports in about 6 months. If there's any Jets fans in the audience, this is what Aaron Rodgers had, so he will not be back for 6 months at least. Ankle sprains, we talked about earlier. The majority of ankle sprains don't get surgery. We treat most of them with therapy. Here's a picture of a basketball player spraining his ankle. That one might take a little longer than a week or two to get back. So the chronic ankle sprains are those are the long-term sprains. They're the ones I mentioned may end up with surgery. So, everybody's an athlete. Insertional Achilles tendonitis, we'll talk about that quickly. That's pain directly on that bump in the back of your heel. That can be related to an injury, overuse, or unknown. Many have a large calcification where that tendon inserts into the back of the heel. Once again, we try to treat this non-operatively. So stretching, bracing, casting, and once again, like I told you earlier, never ever surgery, steroid injections. If that all fails, there are definitely surgeries that we do. Take the Achilles tendon off, shave that bone spur, reattach the Achilles. People do very well, but it's not an overnight cure. It's the same 6 months back to normal. So to go back to our original question, I have heel pain, I must have a heel spur. Well, not really. You can have heel pain without a spur, you can have a spur without pain, and there's lots and lots of other causes of heel pain. This is just a picture I'm showing of what I was trying to describe about having that spur in the back. So that's your tibia, your fibula, that's your heel bone, and this is that bone spur in the back here. That's the same picture now after we've kind of shaved that bone spur away and reattached the Achilles tendon. So this is the last one I want to talk about because this is what scares a lot of people and has us mention surgery and you turn around and run the other direction. Does foot and ankle surgery hurt more than any other surgery? So we do a lot of things to prevent post-operative pain these days. This is not the old days where you just go to sleep, wake up, and deal with the pain. So things that we do a lot of, and I think this has probably been the most important thing of our surgery, is pulling in our anesthesia partners. And what anesthesia does for us all the time on foot and ankle surgery is do a block before the surgery. So what a block does, it's numbing up your leg or your ankle or your foot before we even get to the operating room. It fakes the body out. You eliminate pain before you even have surgery, and by doing that, a lot of the pain receptors never even turn on. So by doing these blocks ahead of time, although it's nice to wake up without pain, it also has been proven to stop that chronic pain or the acute pain that you hear once the block wears off. Including in that, we're very smart these days with the amount of narcotics we use. We mix that in with anti-inflammatories like Motrin, ibuprofen, sometimes Celebrex after surgery. And I think by combining the preoperative blocks and using these combination medications after surgery, we've really cut way down on the amount of pain that people get. And although that's always the question I'll have every time I book a surgery, I think most people are pleasantly surprised at how little the pain is afterwards. So I tried to run through a bunch of things there, about half an hour, not bad. And I wanted to open up to any questions about anything from knee to the toes. We had a question already.
Is a total ankle replacement an option for ankle arthritis?
You had to ask like the toughest question right from the beginning. So I'm going to just give you a quick spiel. So arthritis, from your neck to your toes, is the same problem, okay? You've lost the cartilage between the two bones. If you lose the cartilage between two bones, those two bones rub together, okay? When they rub together, that hurts. In the hip, a hip replacement is probably the top 3 most important medical advances in the history of medicine in the 20th and 21st century. Hip replacements are fantastic. People do wonderfully well. So we never ever fuse somebody's hip. Knee replacements are second best. Those are great. Knee replacements are great. Now remember, the knee, it's about that big of a joint. So when you replace that with metal and plastic, they do great. So we move down to the ankle. So if you go back through the Morning Call archives, I did the very first ankle replacement in the Lehigh Valley in like 1999. and I haven't done them since. Now that's not to knock it. It's just that the first generation, the ones that I did, I thought people did well, but I didn't think they did great. I do ankle fusions, which means taking that bone and fusing them together so they never move again. And I have great results with that. Now it sounds bad that your ankle doesn't move, but most people with arthritis, their ankles don't move anyway. If you are younger, ankle fusions are the way to go. And that is contrary, again, to a lot of the bigger centers. If you're older, then most people do well with either one. But what I would say is that since I personally, am fully admitting it, don't do anywhere near enough of those surgeries, to have an ankle replacement, it's not like knee replacements. We have lots of guys here that do them. The numbers are, if you're going to have an ankle replacement done, your surgeon should have done at least 50 to 60 of them and do at least 30 to 40 of them a year to stay ahead of the curve. So if you're going to get an ankle replacement, I have no problem. I think that's a wonderful surgery. You just have to make sure your surgeon that does them does a lot of them.
What is hammer toe and how is it corrected?
It's a horrible name, a hammer toe, right? But a hammer toe essentially means your toes squinch up, right? So the first thing you do, and you know I'm going to say this because this was sort of the theme here, is non-surgery. So non-surgical, you wear a shoe that has what's called a wide toe box, so a big open space in your toes. If you've tried that and it's not working, yeah, there are surgeries. Essentially, in your toes, you remove the joints, the toe straightens out, and you can pin it, screw it. There's lots of little tricks, but essentially you take a bent stiff toe and make it to a straight stiff toe. So if you tried changing your shoes and you're healthy, you know, you're not gonna have surgery if you don't have good blood flow to your toes, then yeah, there's surgeries to straighten them out. So you go from a bent stiff toe to a straight stiff toe.
Should I see a podiatrist or orthopedist for foot pain?
I'll speak to podiatry. I'm not a podiatrist. I'm married to a podiatrist, so I know a lot about podiatrists. Podiatrists are same 4 years of medical school that we did. However, I spent time delivering babies. The podiatrists don't spend their 2 years doing learning everything about medicine. So I learned pediatrics and OBGYN and surgery and everything. The podiatrists spend their entire medical school they learn medicine and the basics of medicine and the basics of surgery, but their entire 4 years are dedicated to foot and ankle problems. Then they graduate and they do anywhere between a 2 to a 4 year residency as well. So podiatrists are focused on foot and ankle problems only. They don't go above the knee. So our podiatrists are all super well trained folks too, and probably better trained in some biomechanics stuff. So in general, if you're going to go get you're considering orthotics, I'll admit that I think our podiatrists are better at biomechanics than our orthopedic surgeons are.
What is the most common cause of foot numbness?
So the minute you start saying tingling and numbness, that's a nerve for sure. Now nerves in your feet, they can be from your spine, so you get a pinched nerve in your back that causes numbness into your feet. That can be from pinching a nerve in your foot, or it could be from a systemic problem. Diabetes is top of the list there. So anytime it's numbness and tingling, you know, it's sort of on us to figure out where, or at least give you the right direction on where it's coming from. If the numbness is coming because you have a big bone spur in the top of your foot and your shoe smushes the nerve between the bone spur and your foot, okay, then it maybe is a foot problem. But if it's actually shooting from your back, it could be from your back. It could be from diabetes. It could be, well, that's what a neuropathy is. People have probably heard that term. And neuropathies are very tricky problems. Nerves are the most sensitive thing in the body, and once they start to get damaged, it becomes very difficult to resolve.
What are bunions?
So bunions are, number one question, when do you do something about them? When they hurt. You never, like I said before, no such thing as cosmetic bunion, no such thing as preventative surgery. We do bunions when they hurt. And not only do they, you know, first thing, when you have a bunion, I don't want to draw pictures or anything, but essentially your metatarsal goes that way and your big toe goes that way. And that's a genetic thing. And so the first thing you do is you wear a wider shoe, 100%, that's number one. If you've worn wider shoes and you're still having pain, that's when you can start talking about bunions. the point of a bunion, if that's your second toe and that's your big toe going that way, is we need to bring it this way. So it's not just shaving a bump off, but you need to bring the bone from over there to over here. And essentially there's 100 surgeries designed to do that. You can break it down to 2 surgeries. That's all really surgeon dependent. You want to ask those questions when you get there. But essentially you're going to break a bone to straighten out that foot. And it takes different techniques to break that bone, hold it together, and get it to heal.
What is the recovery time for ankle fusion?
For an ankle fusion? So bones take 6 weeks to heal. So again, a fusion is basically scraping away any cartilage, fusing those 2 bones together. So it usually is, in the perfect world, 6 weeks of healing of a bone, 6 weeks of getting used to walking. So usually in my hands, it's 6 weeks of not walking on it, followed by 6 weeks in a walking boot. So usually 3 months beginning to end. All right, everybody got their ice packs? All right. Thanks for coming out. Thanks.